Good afternoon. You're attending the CSG, the Council of State Governments webinar, State Solutions to the Opioid Epidemic. My name is Deborah Miller. I'm the Director of Health Policy here at the National Headquarters of CSG in Lexington. CSG, for those of you who may not know, is a membership organization of policymakers across all three branches of state government. And our mission is to provide our members with up-to-date information to help them in their decision-making roles in state government. So we're pleased to have all of you on the call. I know that everyone is facing some degree of an opiate epidemic in their own state, and everybody is trying to figure out how to have some state solutions, some effective state solutions. And we've got 4 great speakers this afternoon to help us with that. My job right now is to go over a little webinar housekeeping. All attendees are in listen-only mode, but you do have a box over usually on the right-hand side of your screen where you can type in questions as we hear the presenters, and we'll try and get to as many of those questions at the end as we can, so I encourage you to do that. The audio and slides will be posted on our Knowledge Center, and you will receive an email letting you know the link of that within the next week. So moving on, I'm very pleased to introduce today our moderator, Representative Steve Elison from Sandy, Utah. He's in his 4th term as a Utah House member. He's an accountant and currently serves as finance director with the University of Utah Hospital and Clinics. He's passed several bills surrounding issues related to opiates and prescription pain medications in his state. And he's been a member of the 2016 CSG Toll Fellow class. He will speak briefly about some recent legislation he was involved in Utah, and then he will take on his moderator role and introduce the speakers in order as we go through the program this afternoon. Representative Elison.
Great. Thank you, Deborah. It's a pleasure to be with everybody today and talk about this important issue. I wanted to just cover a couple of the bills that I've had the opportunity to work on in Utah. Our session just finished a couple weeks ago, and a bill that I worked on for pretty much most of the year leading up to our session. It passed, I believe, unanimously through all of our committees in both the House and Senate. And what the bill did is, I actually, as a way of background, I talked to the former director of the National Institute on Drug Abuse, and who's a professor of pharmacology at the University of Utah where I work, and asked if there's one thing we could do to combat this issue, what would it be? And this is what the result of that conversation is, this bill. So what it does is it creates mandatory training for all physicians, nurses, dentists, anybody who has a DEA license to prescribe narcotics. And it doesn't increase their continuing medical education, but it requires that over the next few renewal cycles, they have to take a 4-hour course on a program called SBIRT. SBIRT is a program that comes out of SAMHSA and has been the Substance Abuse and Mental Health Administration. It's been around for a number of years. It's very successful. SBIRT is an acronym that stands for Screening, Brief Intervention, Referral to Treatment. So it basically makes prescribers kind of on the front lines of recognizing substance abuse issues, trains them in motivational interviewing, how to talk with their patients about the issue. If they believe the patient has an issue, they can then have them complete a questionnaire that then scores how serious their substance abuse issue may be. And depending on the outcome of that survey, the physician then talks to them about various options ranging from maybe medication-assisted treatment to maybe an inpatient setting or referral to some other setting. And so it trains everybody on that. It doesn't require them to offer the SBIRT service, but as I had a number of physicians tell me, I really like Espert, but if I have precious little time in clinic to do such a procedure. And so what we did is we opened up our Medicaid and our public employees health insurance system, the codes for Espert. Espert is a billable service, and that way physicians, nurses, dentists will have the training and the incentive from a billing perspective to offer this service. And so it really enlists the entire healthcare organization that prescribes opiates to help recognize and get people into treatment to have an issue. So we were very excited about that bill. The fiscal note was actually very low because the service doesn't cost that much, and only about 2% of the patients end up needing it. So I'm happy to put a link out on the website, the webinar materials to that bill. A bill that I sponsored last session, and I believe actually I got the idea from a CSG issue briefing several years ago on needle exchanges. First, I didn't think I'd ever touch something like that, but sponsored a bill last session. We got that bill through Utah nearly unanimously that authorizes syringe exchanges. And you might say, why do we need those? Well, just real quickly, it's a proven harm reduction method that helps reduce the transmission of HIV and hepatitis C. Hepatitis C is one of the most costly drugs or diseases to treat. The drugs can run $80,000 to $90,000 per treatment. And it's interesting. I've heard estimates that 40 to 50% of all patients in the country that are or individuals that are infected with HIV happen to also be on Medicaid. So to the extent that we can reduce the transmission of these costly and serious diseases, then it's going to save our budgets a lot of money and improve their quality of life. When I presented the bill in Utah, I focused on the financial aspects to the state budget as well as the health benefits to these individuals, and I think those were some of the secrets to getting that through. Lastly, another bill I sponsored last year was on standing orders for Naloxone, also known as Narcan. That allows any pharmacist to dispense Naloxone to a patient that's also getting an opioid, or a family member that maybe has a loved one that's dealing with a substance use disorder. They can get Naloxone. It's an opiate antagonist that can pretty much instantly reverse an overdose and allows that person to get into treatment and hopefully back on their feet. We did also fund last session for all of our law enforcement entities in the state to be equipped with Naloxone kits. It can be an injection, intramuscle, or a nasal spray. A nasal spray is much easier to use. Since then, we've had trained 45 law enforcement agencies in the use of that. And since we started offering Naloxone through the state in 2015, we've had 735 opioid overdose reversals, basically lives saved. And we have a couple law enforcement agencies that are actually having a contest to see how many lives they can save. So great public policy, and it's saving a lot of lives here in Utah. So that's just a brief overview of some of the bills that we've done here in Utah. I think we'll move now into our featured presenters. Well, let me run through a couple slides really quickly here. As part of our trying to get the word out about Naloxone, we have this campaign that our Department of Health has been carrying out that talks about the seriousness of opioids, whether it's prescription or illicit drugs such as heroin. And the campaign's called Stop the Epidemic. We've had a lot of billboards, radio spots, and increased awareness of Naloxone. One thing I do need to mention that our needle exchange was really unique, that every person who gets needles exchanged must be given information about Naloxone. They must be given information about testing options to determine if they have been infected with the disease. And then also they are given information about where to seek treatment. So our program was just launched a few months ago and it's taken off. So maybe we can just click through the last few slides here. Again, these are from our Department of Health website, trying to educate the public about opioids in general, and some information about our Opioid Overdose Response Act that I just described. So Thank you, and let me move into our next presenter. I am pleased to introduce Dr. Melinda Campopiano. Dr. Campopiano currently serves as the Chief Medical Officer for the Center for Substance Abuse Treatment at the Substance Abuse Mental Health Services Administration, SAMHSA. She is a physician board certified in family medicine with additional credentialing in addiction medicine. She has worked both in primary care and addiction medicine, including managing programs and patients using methadone and buprenorphine. I'd like to turn the time over to Dr. Campopiano. Thank you for your time, and we will hold questions till the end of the webinar.
All right, thank you for that introduction. Go ahead on to the title slide. It's a great pleasure to talk with you today. I had the privilege of talking at one of your live meetings last December and was really impressed with the level of awareness and very creative problem solving that was in use across the United States. So my presentation today is going to be very brief, and the focus of it is the use of medication to treat opioid use disorder. So medication-assisted treatment for opioid use disorder. To be useful, there's a couple of kind of broader issues that have been alluded to already that I'm just going to touch on very briefly to kind of set the context in which treatment needs to be thought about. Next slide, please. So not to put too fine a point on it, but being alive is the necessary prerequisite to recovery from any substance use. And I think there's a very high level of awareness and sensitivity about the role of naloxone or Narcan in reversing opioid poisoning and saving the lives of many people who would otherwise die from opioid overdose. The situation, of course, nationally is evolving, and I'm sure many of you have heard about, and some of you may be immediately confronted with the issue of synthetic fentanyl analogs that are illicitly manufactured and appearing in the not just heroin supply, but sometimes sold as counterfeit pills. So this is a little bit of a game changer and is driving the ongoing increase in opioid overdose. So some strategic thinking about naloxone. Focus should be on making it available to high-risk populations, and as mentioned already, that means people who use drugs, their friends, and their families. Fentanyl, in particular, is so very fast-acting that it's unlikely that help would arrive on the scene in time to administer naloxone and save the person from dying. The other strategy to think about is opioid overdose, even before the advent of fentanyl, was the leading cause of death in people leaving jail and prison. So training inmates on overdose so that they recognize it and can respond appropriately is an important strategy, a high-yield strategy. And making sure that naloxone is provided to them. Usually this is easiest to do by putting it in their personal belongings so that they receive it on their way out the door. The other step that we're all a little bit challenged with is engaging people who have survived an overdose in treatment and recovery support. And the trick seems to be in figuring out what they're willing to address first. It may seem like, to those of us on the call who have not personally experienced addiction or in recovery from addiction, that one would automatically want to go to treatment as soon as one has realized that they've survived, they've very nearly died. But this isn't always the case. Sometimes there are barriers to treatment, such as unstable or unsafe housing or lack of child care, that may need to be addressed first. So those are just some quick strategies for your thoughts about how to get naloxone out into your community so that people can survive their substance use disorder and access treatment. Next slide, please. Now, the other kind of key point for the conversation is that detoxification is not treatment. Detoxification is better thought of as the medical management of acute withdrawal from a substance. It does nothing to change the underlying disease. So think of it as, somebody comes in and their sugar is way too high, and you correct their sugar, but you don't institute treatment to control their diabetes. Well, you've fixed the emergency and you've probably saved their life, but you haven't changed the course of the underlying illness, which is diabetes in that example. Now, the other thing in the context of opioid use is that most people with opioid use disorder do not need to be to receive detoxification in an inpatient setting. They really only require residential or inpatient detox if they have a significant co-occurring psychiatric or medical problem that's unstable. The other common reason for doing this inpatient would be if they also need to be detoxed from alcohol or benzodiazepines. Both of those substances can be dangerous to withdraw from at home or in a less intensively monitored setting. So by no means do I want you to hear this presentation and think, oh, we don't need detox services in our state. You definitely need them, but you need them mostly for your patients with alcohol dependence and benzodiazepine dependence. So the other thing that I'll just mention, and I'll go into more in a moment, is that once a person's detoxified from opioids, regardless of where that's happened, they are at much higher risk for dying of overdose if they then return to substance use. So it's very important for those people who are detoxed to receive naltrexone. Other medications for opioid use disorder don't require detoxification, but if a person is being detoxed for whatever reason, that's the appropriate treatment for them, they should not leave the facility without being engaged in medication-assisted treatment with naltrexone and provided with naloxone. Next slide. Now, it's kind of natural to think to yourself, why would we want to give medication, opioids in particular, to people with opioid use disorder? Well, the answer to that is that the use of medication in the treatment of opioid use disorder confers benefits that you cannot get any other way. For example, it reduces all-cause mortality by half. So the person on medication-assisted treatment is half as likely to die of anything as the untreated person. So that's overdose, trauma, untreated medical illness, etc. It also reduces the risk of HIV by about half. So you can prevent people acquiring HIV. It may not reduce the risk of hepatitis C quite as much, in part because the prevalence of hepatitis C is already so high among drug users that we may not see that much benefit, but it will certainly reduce it to some extent. I just can't quantify it for you. Medication-assisted treatment for opioid use disorder improves adherence to medical treatment. So it would improve the ability of this person to take their antiretrovirals, to complete their hepatitis C therapy, to take their diabetes medicines, et cetera, et cetera. It improves social function. So you end up with people who can hold down a job, people who can take care of their elderly parents, people who can take care of their dependent children. These are all benefits that we can't say can be attributed to treatment of opioid use disorder that does not include medication. So obviously decreasing criminal behavior is important. And the last one, you might be disappointed to see that it decreases drug use instead of eliminates drug use. But the reason for that is that the medications for opioid use disorder only treat opioid use disorder. And many people have polysubstance use disorders. So in the context of treatment, the other disorders need to be addressed behaviorally, but we can't attribute necessarily, we can't really expect people to be able to stop drinking, for example, because they're on a medication for opioid use disorder. So it's a little bit nuanced, the impact that it has. Next slide, please. Now, the medications that we're talking about when we say medication-assisted treatment for opioid use disorder are three: methadone, buprenorphine, which you may recognize as Suboxone or Subutex, but those are brand names, and naltrexone. The extended release injectable naltrexone you may know as Vivitrol. So methadone and buprenorphine are both opioid agonists, and that means that they act like opioids. They relieve pain, they may cause euphoria if they're taken by somebody who's opioid naive. They can cause sedation and constipation and potentially even death if misused. So they're opioids. I want to be absolutely unequivocal about that. But because we're using them to treat people with substance use disorder, they're generally provided with some measure of control. Methadone is more highly controlled because it is what's called a full agonist, meaning the more you take, the more effects you get, and so the risk of harm is a little bit greater. And buprenorphine is somewhat less regulated. As you know, it may be provided in the same program as methadone. It may be provided in an addiction treatment program of another kind. It may be provided in a doctor's office. It's what's called a partial agonist, meaning the more you take, the more effect up to a point. And then after that, you can take more and it's just not going to do anything. And that's because of the inherent pharmacologic properties. And then the extended release injectable naltrexone is approved for a slightly different indication. It's approved for the prevention of relapse to opioid use after detoxification. Now, this is an opioid antagonist or blocker, and that means that the person has to be completely off of opiates and away from them, detoxed, and then a period of being opioid-free before this medication can be administered. Otherwise, it can make them just intensely ill, like dangerously ill, not like opioid withdrawal, which is bad enough. Next slide, please. Now, so with that in mind, what are the different roles for these medications? And I'm not going to repeat the things that I've already mentioned. But this can be, naltrexone in particular, can be ideal for people who are leaving a controlled setting of some sort, whether that's a detox or rehab setting or jail or prison, or potentially leaving the hospital. If they were admitted with a medical problem and in the course of their admission or their psychiatric admission, they were detoxed off of opioids, this can be introduced right there before they leave the building. There is an oral formulation of this medication, but unfortunately, adherence to it has tended to be poor, so we don't really recommend using the oral form unless you're in a setting where people can be observed taking their medication. Now, this cannot be used by people who may need opioids for pain, and it has an added benefit of helping to treat alcohol use disorder. So it's something to think about in the co-occurring population of alcohol and opioids. Next slide. Now, buprenorphine or Suboxone or Subutex, as I mentioned, is safer to use and therefore tends to be less regulated, does not require detoxification. So the access to buprenorphine, the threshold for accessing it is lower. The person has to be feeling opiate withdrawal, but they don't have to be detoxed to get there. This can be used in pregnancy and is one strategy that many people are using to try to increase access to treatment during pregnancy in rural or otherwise underserved areas. This medication, you should be aware, has relatively few drug-drug interactions, so it's something that should be considered for people who are on HIV medications or other chronic meds. Now, the reason why you often recognize the two names Suboxone and Subutex is that it comes in two formulations. The Suboxone has Naloxone in it, and the Subutex does not. The one that's only buprenorphine, the Subutex, really is only indicated for use in pregnancy or people who have a true, like, histamine, throat swelling, hives type reaction to naloxone. So by and large, you should be seeing the combination product used, and you should encourage its use. Next slide, please. Now, last but not least is methadone. It's been in use for, well, how old am I now? A long time. It is more intensively regulated. It has to be administered directly to the patient at the program, and then once they're stabilized, it can be dispensed to them for home use. It requires certification from SAMHSA of the program, and the DEA must also register the program. Now, this is the best studied of the medications I'm discussing, and it provides all the benefits that I ran through earlier. It tends to be in operation a little bit sort of higher threshold because there's just sort of more rigmarole that goes into getting into a program. And not to get too technical using words like rigmarole, but and then there tends to be more bias against the use of this medication, and you have more work to do as far as sort of re-educating stakeholders and community members about the benefits of this medication. So many people, because we have a crisis in front of us, are kind of not putting a lot of effort into getting methadone out there, which is unfortunate, but that's just the reality of it. Next slide, please. So I'm getting close to wrapping up here. You'll be happy to know. Medication is just one component of comprehensive treatment for opioid use disorder. Very few things can be fixed with a pill. I'm not sure any can be, actually. So while the medication reduces mortality, reduces HIV, improves social function, all those things we talked about, it is not going to make a person happy, healthy, have purpose, and reconnected with life. For those things to be able to happen, people need behavioral therapies. They often need case management because they don't know how to operate in complex systems, which unfortunately are often our systems, but they are complex. And it's important to note that they don't need to get all these services from the same place. So a lot of the important services might be able to be provided in, more isolated communities with intermittent trips into where the medication is prescribed or dispensed. So keep that in mind as you're looking at, how you might design a treatment system that meets the needs of your states and your populations. Next slide. Okay, great. This is my email address. I'd be very happy to answer any questions at any point in time from any of you. And then I will hand the microphone, so to say, back to the organizer so that we can carry on. Thank you for your attention.
Great. Thank you, Dr. Campopiano. It was very insightful. Our next panelist is Robert Childs. He has directed the North Carolina Harm Reduction Coalition since 2009. His career specialized in syringe exchange, harm reduction, community-based overdose prevention utilizing naloxone, law enforcement assisted strategies. Robert has been involved in legislative campaigns on syringe service programs and overdose prevention programs in North Carolina, Georgia, and South Carolina. Welcome, Robert, and we'll turn the time over to you.
Thank you so much for having me today on the panel, and appreciate the time of the other panelists and their service. So my name is Robert Childs, and I'll be talking about what we've done in North Carolina from a harm reduction perspective, and you can move ahead 2 slides. And we're going to be talking today about some of the efforts that we've done in North Carolina, specifically around overdose prevention, kind of some of the collateral consequences of drug use, also talking about some of the issues in our state and how we've responded. So I work for an organization that is the state's only comprehensive harm reduction provider. We do everything from engaging in advocacy, resource development, coalition building, and direct services for law enforcement and those made vulnerable by drug use, sex work, overdose, immigration status, gender, and sexually transmitted infections, as well as HIV and viral hepatitis C. Next slide. And we come from a harm reduction perspective. Basically, it's a spectrum of strategies that work on safer use to manage use to abstinence. But basically, the easy way to think about it is working from a perspective on any positive change and meeting people where they're at. Next slide, please. So one of the things I did want to highlight with the participants today is we're seeing opioid use and abuse around the country, and specifically There's been some recent studies showing that it's increasingly popping up in the rural South. I live in the city, which is recently being rated by the Castlelight study as the worst city in America for opioid abuse in Wilmington, North Carolina. This is a flawed study, but I think it paints a picture that there are problems of opioid use and misuse in the workforce, especially in the American South, where our organization is based and focused on. Next slide. If we're looking from a national model, you're seeing that there's a lot of directly impacted communities in the Southeast area, and also specifically in Appalachia and the Rust Belt. Next slide, please. And in giving you kind of like a local example from North Carolina, we've been tracking overdose death for a very long time now, and as you can see in North Carolina, I think is a similar picture that we're seeing in the rest of the country. It's gone increasingly worse, specifically since 2000, while in comparison, we've been adopting harm reduction principles for motor vehicle traffic fatalities, including what we call like seat belts, driving Volvos, side impact beams, increasing safety enhancements for driving. Again, you can never do driving in a safe way, but you can make it safer, which we call like harm reduction methodology. And good thing across the South and the United States and America, we've started to be taking on these perspectives as well to make people who use drugs' lives safer and hopefully reduce mortality. In North Carolina, again, if you go to the next slide, you can look at some of the more recent trends, and we've had an uptick in overdoses in our state. And if you go to the next slide, what you're going to see specifically recently, as we've been seeing across the country, that North Carolina, we've had an 881% jump from 2010 to 2015 in heroin mortality. And so we've adopted our strategies accordingly. With the increase in heroin use that we've seen in North Carolina, if you advance to the next slide, we've also seen a massive increase in viral hepatitis C. Hep C is transmitted very easily through injection drug use, which is the most popular route of administration of heroin and other drugs that are injected. And so we've seen in North Carolina, traditionally, people couldn't get access to sterile equipment, so we saw a massive rise in viral hepatitis C. This isn't only concerning from a health and public health perspective, but if you go to the next slide, you'll also see we've had a massive rise in the amount of money we've had to pay on treating Hep C. And just amongst the Medicaid population, we had a 530% rise in viral hepatitis C costs. So what we've done is a couple things. If you advance to the next slide, starting in 2013, we're able to pass various pieces of legislation, which I'm going to go through, to try and decrease the negative consequences of opiate overdose and risk behaviors associated with acquiring viral Hep C in order to try to help people less likely to OD, less likely to get HIV, less likely to get viral hepatitis C, and get people more opportunities for second chances. So we've done everything from, which we started doing in 2013, which we passed these bills, which have been also replicated in Tennessee, called Have Syringes Tell an Officer bills. What they do is that we saw an increase in heroin use. We wanted people to be able to declare those syringes to officers prior to a search. And so what happened with this legislation is it allows people carrying syringes to declare it to the officer. If they declare it to an officer prior to a search, the item becomes decriminalized. We know 1 out of 3 officers will get stuck in their career by a syringe, exposing them to HIV, viral hepatitis B, and viral hepatitis C, as well as other bloodborne disease. And we know there's a 66% drop if we decriminalize the syringes and allow people to tell them. And so it's an easy public health, public safety measure, which allows people to declare them prior to a search. In 2015, we amended that legislation to make it very clear that syringes and sharps that had residue in them will also decriminalize. With the early legislation that wasn't clarified. We amended it in 2015 to identify that, because the ones specifically with residue in it, we're extra worried about them having viral hepatitis in the syringes. We also legalized biohazard collection. So before, it was illegal in some circumstances for community-based organizations and public citizens to be able to collect biohazard. We had folks who were criminalized for trying to pick up needles in the park to dispose of them. And so we legalized community biohazard collection programs in 2015. If you go to a couple slides down, that one, perfect. We've also legalized syringe exchange in North Carolina. If you go to the next slide, we passed it in 2016, and syringe exchanges has a variety of benefits, and which is why we promoted them. But specifically, if folks are unfamiliar with the concept, they're public health programs for folks who use drugs as well as anybody who uses syringes in the community. And what they do is, besides giving people the opportunity to get new syringes, they also provide services such as doing referrals to drug treatment, referrals to detox, referrals to mental health providers. We also help people out with gaining some basic access to basic social services, food, and shelter. It kind of provides a non-judgmental place where people can get supportive care, who traditionally are being marginalized and pushed out of most other social services. They're shown to decrease HIV and viral hepatitis C. If you go to the next slide, they're actually shown to decrease the infection rate of HIV by up to 80% and viral hep C by 50%. Also, one of the interesting things is they decrease crime. And like what normally is happening with that is all these folks who traditionally had nobody connecting them with care, nobody helping them with food, nobody helping them with shelter, are suddenly provided a point of resource where they can get that. So folks who are doing basic breaking and entering for some vital needs, if we can meet those vital needs, they don't need to do some basic crimes that they were committing, and instead we're getting them supportive care and services. If you go to the next slide, we also have seen that syringe exchange programs have been incredibly helpful in getting people into drug treatment. We've actually found participants of syringe exchange programs are 5 times more likely to enter drug treatment than non-participants, which is amazing. And if you go to the next slide, again, we pre-identified that syringe exchange programs also decrease needle stick injuries to law enforcement by 66%. And as we see a growing rise of people injecting drugs across our country, where a lot of law enforcement departments, which previously didn't really encounter injection drug users very often, are starting to see that. And a lot of law enforcement officers haven't had needle stick prevention trainings before, which talk about how for them to maintain their safety around injection drug users. And a lot of them are getting accidental sticks. So it's really important that programs adopt these laws to protect law enforcement safety and community health and safety of people who use drugs and people who love them. And it's not just public health officials who are supporting it. In North Carolina, for example, if you advance to the next slide, we have an example of a fact sheet that we use which identifies law enforcement across the state supporting syringe exchange. We have everything from rural, suburban, and urban law enforcement coming out to advocate for syringe exchange programs because they understand the community health benefits, the benefits to the community members, as well as the benefits to law enforcement. If you go to the next slide as well, what we also address with syringe exchanges is that they make fiscal sense, right? So an HIV infection can cost up to $630,000. A viral hep C infection requires liver transplant, can cost $500,000. We know we can prevent all that with a 7-cent tool. So for most people, it's just obvious fiscally, why wouldn't you support such a program? As well as programs that, another thing really neat thing about them is they're also shown not to promote drug use, even though a lot of people think counter to it. And again, it's because it's providing that access point for caring services. If you go to the next slide, you can see what we've been able to do in North Carolina in a very short amount of time, which is as of February, just within 8 months after passing the legislation, we've been able to set up 18 active syringe exchanges around the state, which are covering 18 counties. And they've already, just from the Wilmington program, which is in the southeast corner, we've already been able to get over 50,000 needles off the streets in that jurisdiction in just those few months. So if we can get these programs up, we can start getting syringes off the streets and making our communities a lot safer. If you go to the next slide, one of the other things we've been able to do in North Carolina is pass Good Samaritan laws. What Good Samaritan laws do is they provide immunity for people calling 911. So they can vary in what they're protecting, but normally what you'll see is they'll have protections for people if there's paraphernalia on scene, controlled substances, sometimes other violations. And the whole point of them is to get people to call 911 and not fear calling 911. Georgia has a fantastic law which protects from arrest, charge, and prosecution. In North Carolina, they only provide immunity from prosecution. Each state's a little different, but again, they give some protections for people who want to call 911. So say, for example, a parent comes home and finds their kid overdosed. We don't want the parent fearing calling 911. We want them to call immediately, and that's what Good Samaritan laws promote, and increasingly those kinds of laws are being passed across the American South, including the first law which came out of Florida and then North Carolina. In North Carolina, if you go to the next slide, we passed two of these laws in 2013 and 2015. And what was kind of unique in 2015 is we added protection for people in parole, probation, and pretrial release. If you go to the next slide, the previous panelists have kind of talked about naloxone. One of the key things that has been associated with naloxone, which was shown in British Medical Journal, is if you expand access to naloxone specifically to people who use drugs and people who spend time with them, what you'll see is there could be up to a 50% drop in mortality if you provide easy access to the medicine. Also, what we know is when states that are increasingly seeing more and more fentanyl use, it's incredibly important to give naloxone to people who are going to be on scene, because sometimes those overdoses are going to happen a lot faster, and especially in rural environments where it may take up to 20, 30 minutes for EMS or first responders to get on scene. That could be too late. So we want naloxone on site where people are using drugs and to get it to them so they can easily use it. If you advance to the next slide, there's all kinds of different protections you can offer for naloxone. We're happy to talk about that more, or people can contact us. But basically, you want to provide as many protections as possible and provide civil and criminal liability protections for the prescriber, for the pharmacist, for lay administrator, dispensers, and also for the distributors to try and get as much naloxone out there as possible to people who use drugs and people who are likely to be around them. Network for Public Health Law has a great resource on this, and people are welcome to contact us if they have any questions about it. If you go to the next slide, we passed 3 different naloxone expansion laws. First one, which came part of that, it was a Good Samaritan naloxone combo law. In 2015, we amended the legislation to also allow pharmacists to do standing orders distribution. And in 2016, we enhanced that to allow the head of DHHS to issue a standing order at every pharmacy in the state. And again, I'm happy to answer further questions on that in the Q&A section. If you advance to the next slide, you can kind of see what's occurred in North Carolina. We passed out around 40,000 overdose reversal kits, which include naloxone in the kit. And we've had over 6,500 overdose reversals now as of today. In the slide here, we only have up to February of this year. But you can see we've been able to do a massive amount of overdose reversals, and these are just people who use drugs and people who love people who use drugs. This is not EMS, this is not law enforcement. And you can see just since 2013, we've been able to do over 6,500 reversals. If you go to the next slide, you can look at it, how we've been able to do it by month, and you'll see that, you know, over time, we've become a lot better at what we do and finding the right places to distribute, but also the epidemic's gotten worse. And you can kind of see how that flows over the last couple of years. You can go to the next slide. The other thing that we also recently started tracking data on, which I think is interesting to a lot of folks, is how many doses we're actually using to bring people back. And as you can tell from our data, you know, there's been a lot of like national alarm over dosage and what to use, but we're actually finding most in North Carolina only requiring 2 doses to come back to life of the lower dosage naloxone. So just wanted to share that information, and I'm happy to talk more about that in Q&A. If you go to the next slide, also we just wanted to compare it to the law enforcement overdose reversals in our state. And as you can tell, there's a lot less overdose reversals by law enforcement. So if you're looking at what's more effective, both are actually good at saving lives, but what you'll see is with our program in community settings where we're giving it to drug users, we've had 6,500 reversals, and with law enforcement, we've only had 482, both for saving lives. If you go to the next slide, you can kind of see statewide, it's kind of replicating the high concentration zones that we had in community settings, but giving it to drug users, they can reverse the overdose on scene, which is excellent. And you can go forward a couple of slides to the fair hiring slide from now. So the other thing we do, we had legislation introduced today, which will do fair hiring / what we call ban the box legislation. What it does is it provides individuals in our state who applying for state employment, they can't be discriminated against for previous criminal record. You can go to the next slide from there. And what it does basically is it bans state employers from asking about people's criminal histories prior to the job offer. What we want and what we know is people with criminal histories have a very hard time getting access to work because oftentimes they've been asked about their criminal histories on their job applications. We want to not have them be discriminated against. We want them to have opportunities to work. If you go to the next slide, and go one more slide, please. What we'll find is, like, if we do give people opportunities for work and give, especially with criminal records, we're going to see a decrease in recidivism. We're going to see more people with criminal records hired. We'll also see that the criminal record was not a barrier to employment amongst employees. And you'll see that if we actually hire people with criminal records, they're just less likely to commit crimes. They're less likely to have to go back or potentially go back to drug use. They're less likely to have difficulties. And we know if we can help get people employed, there's going to be a lot less problems down the road. The last initiative I did just want to talk to, if you go to the next slide, is we've also been promoting a model called Law Enforcement Assisted Diversion, which is a pre-arrest diversion program. So we're trying to prevent people from getting criminal records and try and connect them to care. So what it does is it allows officers to use law enforcement discretion to divert low-level drug users and sex workers to social workers who are going to assist them with connecting them to housing, drug treatment, harm reduction services, mental health services, job training, and other referrals. So instead of giving that person a criminal record, instead of holding charge against them, what we're doing is referring low-level offenders to social services who are going to help those folks get connected with care and work with them on any positive change. And there's currently lead programs in Seattle, Albany, New York, Santa Fe, Fayetteville, North Carolina, which is one we're helping out with, Huntington, West Virginia, Baltimore, and Portland. I mean, in North Carolina and the American South, there's a bunch of programs that are about to pop up as well. And if you go to the next slide, what they're doing, again, is they're trying to, instead of incarceration, offer them wraparound care to hopefully keep them out of systems of incarceration. So we're going to try and help them with education, healthcare, housing, which is a huge one, job training and treatment. And again, if they aren't going to be discriminated against for their criminal record, it's going to be easier to place them and get them to break the cycle. If you go to the next slide, the major stakeholders in the program are law enforcement, service providers, and the legal system. If you go to the next slide, you can see where these programs are popping up across the United States. And if you go to the next slide, there's been some good evaluation on them. We're seeing lower recidivism, less time people are spending in time in jail, reduction in felony cases. We're spending less money on them because they don't have to be incarcerated. And we also see improvements in a relationship with law enforcement and a community. And with that, I'll end my presentation and take any questions at the end.
Thank you. Appreciate those great insights, Robert. Our last panelist is James Giglio, and he has more than 38 years of experience serving in management, executive, consultant capacities in the fields of public health and law enforcement. Jim retired as the director of the New York State Bureau of Narcotic Enforcement, where he managed the statewide drug enforcement and regulatory program and the state's prescription drug monitoring program. Mr. Giglio is currently serving as the director of the Prescription Drug Monitoring Program, Training and Technical Assistance Center at Brandeis University. We'll turn the time over to you, Jim.
Well, thank you, and let me let everyone know, if you're hoping to hear from Jim Giglio, this is not Jim, this is Pat Canoe. I'm over the, I work with Jim at the Training and Technical Assistance Center, so you'll get to hear from me today. I'm going to go a little bit fast through this just so we have enough time for questions at the end. My talk today is going to cover a little bit of the overview of monitoring programs, some of the history and the current status of the monitoring programs around the country. As you can see on the slide in front of you, it gives a brief definition of what a monitoring program is, but basically it's a doctor writes a prescription, gives it to a patient, the patient takes it to the pharmacy, and the pharmacy fills it and then transmits the data to the state monitoring program. The data is then made available to authorized users such as doctors or pharmacists, law enforcement, regulatory boards, a variety of users, which I'll go into a little bit more in a second. But basically the monitoring program is just a tool, and the different users use it for different reasons. For example, doctors and pharmacists will use the monitoring program data to help them with proper medical treatment of their patients, possibly identify patients who may be at risk either from an overdose or the combination of medications that they're taking may cause some adverse reaction. Law enforcement will use the data to further their investigations on violations that involve controlled substances. Licensing boards will use the data to monitor their licensees to ensure compliance with board actions or perhaps some license restrictions. Around the country, every state except for Missouri and the District of Columbia has an operational monitoring program. I said Missouri does not. They currently have some legislation pending for a statewide monitoring program. But in the meantime, the County of St. Louis, the Department of Public Health, County Department of Public Health, passed an ordinance, a county ordinance, establishing a monitoring program at the county level. And what's unique about this is that they have invited other jurisdictions around Missouri to participate with them. So in effect, they may get a patchwork monitoring program that covers the whole state, run out of the County of St. Louis, and that's supposed to be operational next month from what we understand. If you can go to the next slide, please. This graphic shows the current operations of monitoring programs for the most part around the country. The initial monitoring program started many years ago. In fact, the first monitoring program was established back in 1939 in California. Other states added it throughout the years. The original monitoring program was tracked basically just Schedule II controlled substances, and the information was only available to law enforcement and licensing boards. It then expanded, the second generation, we'll say, up to from the start of the programs to about the mid-90s. They expanded access to the data to healthcare professionals like prescribers and dispensers. This model up here is the current model for many of the monitoring programs, where you can see they've added in additional users. For example, medical examiners, drug courts, other state monitoring programs to share data across state lines, Veterans Affairs, Indian Health Services, Medicaid, Medicare. They keep expanding who has access to the data because the data is of such value. Also, the method by which users can have access to the data has expanded. Before, in most states, a person had to get an account, log in to the separate system to get it. Now many states are integrating the prescription monitoring program data with their electronic health records or health information exchanges. And there's been great progress in interstate data sharing, where there's 2 operational hubs allowing the monitoring programs to share data across state lines to users in other states. Next slide, please. What I'd like to cover briefly is just the data that's actually collected. There may be some misinformation out there. It's basically what's on the face of the prescription. It has some patient information, the name, address, date of birth, in many cases the gender. It has the prescriber's information, typically the Drug Enforcement Administration Controlled Substance Registration Number, and the same for the pharmacy. From those 2 data elements, the PMP has the ability to link to the DEA licensing file to get the name of the doctor or the pharmacy, the address, in many cases phone number. It also includes the drug information, the name, the type of drug, the strength of the drug, and that's typically provided by an NDC number, a national drug code. It has the quantity of the drug that was dispensed and the date. It has the days supplied for that particular prescription, and in many states it has the source of payment. That's basically what all the states are collecting, common amongst the states. Next slide, please. My next series of slides, may take a second to load, are just some of the current status of the monitoring programs. And I'm going to go through these very quickly just because we're running out of time. This one shows data collection frequency. Of course, the fresher the data, the more value it is. As you can see, there's two outliers in there. Oklahoma in that darker blue, they collect the information from point of sale, and the light purple in the bottom left-hand corner is Guam. They collect the data every 14 days. The predominant one is green. Those states collect the prescription data every night. It's transmitted to the PMP nightly, so it's as fresh as you can get. Kentucky did a study when they were deciding whether or not they had, whether or not they should go for real-time access at point of sale or daily. And to the study that Kentucky did, they determined that the cost of going real-time was not worth the benefit, so they chose to go to daily transmission. Next slide, please. This slide shows, if you can go back one, please. Well, I think we skipped a couple ahead. One more back, please. Okay. These next three slides show solicited and unsolicited reports. The solicited report is basically someone logs in and asks for it. They go to get the data on one of their patients for prescribers. Unsolicited means that the monitoring program has noticed something with the data that should be brought to the attention of the authorized requester. So this slide shows the states that are engaged in sending solicited and or unsolicited reports to prescribers. The blue states, which is the majority, are doing both for prescribers. Next one, please. Next slide. This one is for dispensers, and it changes a little bit. There's more doing solicited only as opposed to unsolicited to the pharmacies. But the information is more timely value to the doctors actually seeing the patients initially. So solicited to doctors has a greater rate than, or having the authority to do unsolicited reports to doctors than dispensers. Next, please. This is a similar slide, except it's for regulatory and licensing boards. You can see the majority of the states are just doing solicited reports, meaning some investigator at the licensing board has to request the data on one of their licensees. The yellow ones are ones that are not currently sharing the data with the licensing boards. The next slide is law enforcement. Many states have certain conditions under which law enforcement can have access to the data. For example, a court order, subpoena, search warrant. A number of states have where it's just they have to be engaged in an investigation of criminal violation or have probable cause. And so you can see the majority of states do not allow unsolicited reports to law enforcement. Rather, the law enforcement has to go and specifically ask for a report of the monitoring program data. Next one, please. This one's drug courts. The amount of states actually sharing data with drug courts is not as great as some of the others, but it is expanding across the country. Next, please. And this is for substance abuse treatment providers. Again, there's some work that needs to be done there across the country. Next, please. I know I'm already over time here. Medical examiners and coroners. This is a relatively new user around the country, but you can see it's it's spreading quite nicely, and it just makes sense with the number of overdoses around there. It would be helpful for the medical examiners to try and identify if there was a prescription drug involved in the patient prior to the death. Next, please. Another recent occurrence is mandating the use of the monitoring program for prescribers and dispensers. Obviously, the data doesn't do anyone any good unless somebody uses it. And since historically there's been a lower rate of use of the monitoring program, many states have passed mandatory queries. Oftentimes it's just under certain conditions, such as the initial prescribing of a prescription to a patient or an opioid prescription every 3 months, things like that. So you could see that the blue ones are prescribers and dispensers are mandated to query the monitoring program. The green ones are just the doctors are required to query the monitoring program. Next, please. Interstate data sharing. Every state that's listed there in blue is engaged in interstate data sharing with at least one other state. Not every state in blue is sharing with every other state in blue. It's more predominantly sharing with their border states. So you can see most of the states, even the green ones, are at some point of implementing it, and we expect Georgia, Pennsylvania, and D.C. To be online soon with interstate data sharing if they're not already. So it is spreading across the country, and there's been talk of doing some studies to try and determine the effectiveness of, for example, someone in Maine checking California for interstate data. They're trying to come up with some algorithms to pinpoint which states have the highest likelihood of getting a positive result during a query so that there's not wasted time doing a query that's unnecessary. And last one, next slide. This is contact information for me, and I encourage you to visit our website. We have all these maps and more on our website to show you the effectiveness of monitoring programs and their capabilities. All that's on our website for you, as are these slides. And I know I went through quickly, but it's my understanding these will be posted. But if you don't get to the copy that's posted here, certainly visit our website, and we have all that information listed there, and it's updated continuously. With that, I will turn it back over to you, Steve.
All right. Thank you very much, Patrick, and I'm sorry for the wrong introduction there. Jim had a last-minute conflict. We are about out of time, but I am going to ask just one quick question of Patrick related to PDMP. Just earlier today, I was talking with a physician about non-opioid directives. Alaska and Connecticut are currently considering legislation where a patient can put a non-opioid directive in their medical records so that physician won't unknowingly prescribe them an opioid that could put them back into relapse. The discussion we had earlier today was whether or not in our state's prescription drug monitoring program that could actually host these non-opioid directives. So when a physician logs in before prescribing a patient an opioid, they could see that pop up and see that that patient had requested that they not have an opioid prescribed to them, which could then lead to a discussion about, why they're there to see them for an opioid. Do you know if any states have considered integrating the non-opioid directive with their prescription drug monitoring program?
No, I'm not familiar with any. However, a number of the programs are doing some innovative things, connecting to other sources of data to bring that in so that it's all integrated with the monitoring program data. So that being said, adding another type of record to tie to the monitoring program is certainly technologically possible, but I'm not aware of any state doing that currently.
Great. Thank you. We'd like to...
I'm sorry, the closest would be Wisconsin. They've passed some interesting legislation integrating some of the information from law enforcement, and so they're working on that. In fact, I think it went operational last week where they're bringing in some of the information from law enforcement agencies. So that's probably the closest I can think of doing something along those lines.
Great. Thank you, Patrick. And I'd like to thank all of our presenters that have participated, and I will now turn the time back to Deborah Miller to wrap up.
Thank you. Thank you all of our presenters and Representative Elison. I think we got some wonderful information. You'll receive, all of you who are on the call will receive an email in the next couple of days letting you know that the slides and audio have been posted. Some of our speakers are also going to help us with posting some additional information from their organizations that might be helpful to you as you look at what kinds of solutions to take in your state. And I think lastly, if there are questions, everyone who was on this call has very generously offered to answer questions. So feel free to use the contact information for each speaker and reach out to them specifically with your questions. That's very generous of our speakers, and we appreciate that. And we'll wrap up for today. Thank you very much.